All right. All right, great. So this is what I just shared with you, but it's basically how I got to where I am today, taking a variety of positions and roles. These are our learning outcomes. We're going to be describing the role of the SLP in the neonatal intensive unit, specifically related to the 6 core practice domains outlined by the American Academy of Pediatrics. Then we're going to talk about some basic information regarding brain development and how it relates to swallowing. We'll be identifying some pre-feeding and feeding skills. I'll show you a few videos that are related to case studies. We'll talk about how we can do instrumental swallow studies in this population. And then my last slide is really focused on, if you're interested in this population, how you can learn more, whether it's podcasts, websites, continuing education opportunities. Okay, so let's go here. First, we're going to start at the beginning into some background knowledge. So when we're talking about a neonatal intensive care unit, there can be different levels of a NICU. And you might hear that when looking at certain hospitals and seeing what NICUs they have available, it'll come in a level 1 to a level 4. So 1 is a well baby nursery, and then up to a level 4, that's the most critical, most complex NICU that's available. So they go into specifics about what ages of infants that they have in their NICU and what medical care they have available. I specifically work right now at a level 4 NICU at Mount Sinai in Manhattan. So there we are expected to treat the youngest of our babies that are born. We have to have 24-hour care related to medical and surgery specialists in case any of our patients need immediate care. And a lot of the times also we might get transferred patients from other hospitals. So we might have parents who have babies that aren't local to Manhattan or local to specifically the Upper East Side where I am, but their baby might have to be transferred there because of whatever condition or diagnosis that they might have. So why is our career more prevalent right now in the NICU? Why does it seem like there needs to be more training and more clinicians involved? A lot of it is due to increases in prematurity, and luckily, due to the medical advances that are available in the field, we are able to keep infants who are born earlier alive, where we weren't able to do that even 20 to 30 years ago. So as of now, 1 in every 10 babies are born prematurely. And even though we are able to keep them alive earlier and earlier, that doesn't mean that it doesn't come along with more medical complexities. These babies really then need our help because they're being asked to do so much more than they would have been doing if they were still in their mother's womb. So when we're talking about prematurity, if you're thinking of someone who is carrying a baby, they're used to being told that their due date is approximately 40 weeks from when the fetus was conceived, right? So that's what this chart is based off of. So we're thinking anywhere after 38 weeks to 42 weeks is full term. Anything before that is considered premature, and there's varying levels of prematurity. Very premature is 28 weeks to 32 weeks, but now we're seeing extremely premature fetuses that can be born at 24 weeks. So if you're thinking of someone who is pregnant or carrying a baby and they're at the 24-week mark, we're now able, if that mom has a complication or if that fetus is in respiratory distress or if something occurs where it wasn't supposed to and the mother or the fetus's life is at risk, now they can be born and be viable, stay alive. But again, when babies are born that extremely premature, usually the doctors preface that family by saying, expect yourself to be here until your baby's due date, because they have to learn all of those milestones that they should have been learning and practicing in the womb. And now it's going to be a much more challenging environment. So at my NICU, I've seen babies born as early as 22 weeks. and they survive, they go home, they end up thriving. And I think that's why I really enjoy working with this population, is I see miracles happen every day, and these infants are very resilient, and so are their parents too. And then some factors for prematurity that might make it more likely: if there is a parent who's carrying twins or triplets, typically when that parent is going for their follow-up and prenatal care, they're told that they likely will not be able to carry till full term, just because there's not enough room there for the mother to continue for 40 weeks. If there was any issue of substance use during pregnancy, sometimes stress, hypertension, high blood pressure, if there was any infection, any anatomical abnormalities, and then sometimes maternal age could play into that as well. Okay, so when we're talking about prematurity and age, if we're talking about gestational age, that's the number of weeks that was completed in the mother's womb. So for example, 24 weeks were completed and then the infant was born. Post-menstrual age is then talking about how old the infant is, considering the number of weeks spent in the womb and then the number of times spent outside of the womb. So if I'm going, for example, someone who's born at 24 weeks and now they're 1 week old, I wouldn't be treating them as a typical 1 week old who was born full term. I would be treating them now as a 25-weeker. So it's really, that's just used as a post-menstrual age, as like an awareness and reminder to us that even though their chart might say they're 1 week olds, they're a month olds, they're 2 months old, really we need to remember how early were they born, because we can't compare them and their milestones to their peers that were born full term. And that's really helpful to know if you ever are working in early intervention with that birth to 3 population, because that age is adjusted for and those milestones are adjusted for up until the age of 2. So if someone was born extremely premature, so say if they were 5 months old, but they were born 4 months premature, I would expect them to only have speech and language milestones and feeding milestones of a 1 month old, because we are allowing them to have that catch-up time compared to their full-term peers. It's not really fair to compare them to that when they've had to deal with learning how to breathe on their own, feed on their own. They're not developing at home, being held by their caregivers as much, and they have to go through all this medical intervention. So if you work with that young population, that these might be some terms that you might come across. And then they consider after 2 years old, you should really be caught up with your milestones, and there's no longer adjusting of age at that point. So now we're going to be going into our roles specifically as speech language pathologists in the NICU. So these are the 6 practice domains that I spoke about in terms of our learning objectives. So I'm expected as a speech language pathologist to know and be familiar with all of these domains. So I think sometimes it might be a misconception that in the NICU, our role is only to work on the feeding and swallowing, but really in the NICU, we kind of introduce ourselves as neonatal therapists, me, occupational therapy, and physical therapy, because we're all expected to know this broad knowledge. And there's a lot of overlap at this specific age within our professions. So we all have to know this. So we're going to be talking today about the NICU environment, family support, the sensory system, the neurobehavioral system, the musculoskeletal system, and then get to some feeding and swallowing knowledge. And then shortly, if we don't want to talk about the 6 domains, and then if I'm giving an elevator speech about what I'm doing in the NICU, then I say I'm in general trying to protect the brains of these infants who are here. I'm trying to foster nurturing relationships between them and their caregivers who are going to be taking them home. And then I'm trying to promote developmental experiences that they usually would be getting at home, but that they can't because now they're in their hospital. So development, relationships, and protective care. Okay, so let's go into the environment. You can chat this if you'd like. What differences do you notice between this fetus here, who is in the mother's womb, and then compare it to the picture that I have above, that is a picture I found on Google of a NICU environment. That's pretty typical of what it looks like. Yep, bright lights and noisy, perfect. Isolated versus many people, very good. Yeah, safe and warm, busy, chaotic, perfect. Many people, yep, great. So sometimes I think it's hard to keep this in mind. And from you guys seeing this and just comparing pictures, you were able to pick out some really good differences. But all of these differences between the womb and the environment really do affect their development and affect the relationships between the caregiver and the infant. And then again, our differences in development. So we can go now into more of that. So like someone said, bright lights compared to dark being in the womb. Also, this is something that's different is the sound exposure. So if you're in the womb, you have muffled sounds. Compared to the NICU, it's actually a very loud place to work. There's always monitors going off, there's people talking, there's noises from the different machines. In the womb, you're constantly contained in like a fluid-like environment, and you're only moving within fluid and no one is touching you. Compared to in the NICU, you're going to be handled by nurses, by therapists like me. You're going to be getting procedures like your blood taken, an IV in, a feeding tube. So it's really, they're not used to being touched that much, and they shouldn't be. But now that they're born here, we kind of have to figure out how to work with the environment. Also in the womb, their temperature is being regulated constantly by the mother. And then in the NICU, they have to learn how to do that by themselves, which is itself its own milestone. And then this is what I mentioned earlier, fluid environment. But in terms of motor wise, being able to move, like if you ever have, a family member or a friend who's pregnant and they talk about, oh, the baby's foot is here, oh, they're kicking here. They're constantly moving in an environment compared to usually when they're in the NICU, they're on their back a lot of the time. And they're not getting that free range of motion to just move as they can. And it does affect their ability to have tone and their muscle development. So all of these factors do make a difference for them. So in general, we're asking them to do way more than they're supposed to do or that they were expected to do if they were able to continue to full term. Differences for the parents. So this is something that we need to keep in mind, especially because we're supposed to support the family system. If you have a parent where a baby is born at the delivery date or full term, they're expecting maybe a day or two in the hospital. A lot of the time, hospitals want to get them in and out. Compared to the NICU, when are we going to get a leave? I don't know. Whenever your baby's able to meet their milestones. So it's a lot of uncertainty. At home, you're in the comfort of your own home, your own schedule for sleeping, bathing, feeding. Here in the NICU, you're running on the nurse's schedule and the doctor's schedule. That gives you a lot less feeling of control and feeling really like you know what's best for your baby and that you're a parent. Also, a lot of the time, these births, premature births, the parents have other children that might be toddlers or school age or even older teenagers. And again, depending on the complexity of the NICU, it might affect that the parent might not be there with their baby all the time because they have to take care of the kids at home or drive them to school, or they're coming from an hour and a half away. So it is really hard for them. And then other things that we might not even think about, like newborn photo shoots, celebrating milestones. A lot of the mothers in my NICU never had a baby shower because they were told that they were having a high-risk pregnancy or their baby was born 4 months early. So why would they have a baby shower? So something we did in our NICU was throw our moms a baby shower a few months ago. And it was actually really nice because the 10 moms who came all didn't have a baby shower. And they were like, it's really hard in this environment to have any kind of normalcy. And they really appreciated it. But in general, these moms feel stressed, these parents are traumatized, they're eager for their baby to come home, and they weren't expecting to be in the NICU. Likely that wasn't within their birth plan. So we really need to prioritize them as the center of their baby's care and help them feel comfortable in what they're doing. Now, if we're talking about the environment, these are the different kinds of beds that you might see in the NICU. The first one is an isolette, which literally looks like a little box with portal holes. If a baby is in this, it's usually if they were born very premature or extremely premature and they aren't able to regulate their temperature yet. So that little box, that isolette, is able to be set to a certain temperature. So that way the baby doesn't have to regulate their temperature on their own. It keeps it humidified and moist and warm. So it's basically, again, mimicking like a womb. Then if they graduate to the middle, which is a bassinet, they're able to have their temperature on their own. And then if they get a little bit older, now they're in a crib. These are the different kinds of feeding tubes that you might see. One is a nasogastric tube on the left, which means it's a tube connecting from the nose to the stomach. Then there's an orogastric tube, which is from the mouth to the stomach. And then a surgical tube that might be needed if a patient is having trouble feeding or they think it's going to take a long time for the baby to be able to eat by mouth would be a gastrostomy tube. And this is a misconception, but babies who have all three of these tubes, they can still eat by mouth. Just because they have a feeding tube doesn't mean that they're not able to bottle feed or breastfeed as well. They still can do that. It's more that if you're worried that they're not able to meet their nutrition and their calorie needs fully by the bottle or fully by the breast, and they need help, then that's usually why they have a feeding tube. Some types of respiratory support if these babies can't breathe on their own. The most severe would be intubation, which is on the left, which is a breathing tube going from the mouth to the trachea to keep the airway open. Then there's CPAP, which is just positive airway pressure. Low flow nasal cannula, which might be something that you're used to seeing more, which is just a nasal prong with oxygen. And then a surgical intervention would be a tracheostomy tube, which is an artificial airway that's made right here in the trachea. Now we're going to go into some development for these neonates. So if we're looking at this picture, I told you I've seen infants as early as 22 weeks born. And now we're comparing this to the right side, which is a full-term infant. It's a really, when the first time you see it, it can really be like, oh my gosh, I am, shocked by seeing this because you're really seeing an infant on the left who, this baby in particular, is orally intubated, can't breathe on their own. You see there's no fat, no cheek pads, no bulk really to this baby. There's, lines everywhere. The baby has a feeding tube and it's just so tiny, can be a pound or could be less than a pound. And then comparing to a full-term infant, and then they just look like completely different beings there. So we have to treat them as not the same as our full-term infants and what they should be doing. And this is a really good visualization of the difference between. So if we look at the right picture, a 25-weeker, their brain is fully smooth. There's no fissures yet. There's no gyri. So we're literally working with these babies before they develop any neurological connections between this is a good experience, this is a bad experience. And so we're literally working on their brain developing. So that's why this is something I share with parents and something I share with nurses, as we can't treat them compared to full-term infants, because look at how much more developed the brain of a full-term infant is on the right. It's almost looks similar to an adult brain. So we're really starting out with a smooth, clean slate, and we need to keep in mind this picture on the left is that every time we touch an infant, every time we care for them, every time we feed them, change their diaper, we are literally laying down neurological connections. So we're responsible for understanding the brain development and how that's going to affect them in the long run. This is then going to lead into our knowledge of the senses. So we've always been taught that there's 5 senses, but there's actually 6. So the first one to develop in infants is touch. So that's important because most infants in the NICU receive touch that's more related to pain. So even if you're taking their temperature, that's something that's very painful for them. If you're moving them to change their diaper, it's again something painful. So then compare it to something like taking blood, putting an IV in, changing tape on their face. That's all this negative touch. And there's research that shows that 90% of the touch that infants receive in the NICU is procedural touch. So they're only touching for a reason. Compared to at home, you would be touched all the time, being held, being rocked, being cuddled. And if it's because the parents are far away or because maybe they don't feel comfortable touching their infant when they have so many wires and lines on them, it can impact and outweigh that procedural touch compared to that comfort and loving touch. The sense that is second and maybe is not as well known about is vestibular. So that's really just orientation of space, motion and balance. So again, if we're thinking about the womb, they're moving within like a gel, environment, fluid environment compared to when they're out in the NICU, they're fighting against gravity. They don't have anything to help move them. Then comes hearing, then comes taste, and then sound, and then vision. And we'll go into each of these. So if we're trying to help infants outweigh that negative touch, these are some things that we can promote or encourage parents to do. So actually, infants, when they're born premature, they really benefit from being in a position that mimics how they were in the womb. So if we see the first picture on the left is giving support to their head and their feet, it's just mimicking like how they would be if they were in the womb. It's called like a facilitated tuck. We could also encourage parents to have the baby skin to skin as much as they can as possible. That's going to benefit both the baby and the parent. And then also we can teach them how to give a little bit of massage to the baby too, to help calm them. In terms of helping how they move in space, there are specific aids, like positional aids that are on the left, again, to put the baby in a position that mimics how they would be in the womb. So they're not fighting against gravity, so they're not constantly touched. So they feel like something is containing them compared to just flailing, around and not having anything to go against. Swaddles are very popular in the NICU, whether it be a blanket or it be a sack like this one. And then we usually also have rockers or swings too. For terms of scent, what we could do to help them, some NICUs have scented cloths. So they could be cloths, they could be blankets that either the parent might sleep on or put in their shirt just to get the scent of them. And then they could put it next to the baby, say during when they're getting a painful procedure. So just that they smell the scent of their parent and they feel comforted if the parent can't be there. In the middle, there's these cloths, these like yarn cloths that are in the shapes of an octopus. And basically they help infants too, because the legs of the octopus look like the umbilical cord. So instead of the infant maybe reaching for their feeding tube or the oxygen, they feel the comfort of grabbing onto something that felt familiar, like it did in the womb. And then lastly, helping with smell is the skin to skin again. If we're talking about taste, we can provide them with breast milk, breastfeeding, giving them a little bit of sugar on a pacifier. That really helps during procedures too, to help calm them down. Sound, each NICU should have something in place, whether it be quiet hours. So they shouldn't be exposed to loud sounds because their sound isn't fully developed yet. So this is something that could disrupt sleep, that could lead to hearing loss. So it's one of the most easily controlled things that we can do if we're walking into a unit is to keep our voices down. So right now I'm guessing I'm probably speaking at like a 60 to 70 decibel level, and infants should, specifically premature infants, shouldn't be exposed to more than 40 to 50 decibels. So that would be more equivalent to me at a whisper compared to me at conversational talking. So in order to help that, some units might have between the hours of 10 to 12, please refrain from speaking unless it's like something that's important, or quiet hours. There could be sound machines to help the babies go to sleep. And then we also have music therapists in our unit. In terms of vision, again, we're talking about the womb that was dark compared to now the NICU bright lights. So there should be also a policy about when lights can be on in the room compared to be off. We would like them to be off so the infants can go into a deep sleep, and during sleep is the only time that their brain is developing. So we really encourage that and don't want to disrupt them. And then also, if we have any babies who are jaundiced and need light therapy, that they're going to be constantly exposed to light, we do have felt glasses that can go on them to protect their eyes. If they're exposed to too much light too early, it also could lead to vision loss and needing for glasses really early in life. Next, we're going to go into some subsystems of the infant. So the 5 subsystems that we look at are autonomic, so that's the basic life functions: breathing, temperature, blood pressure, and coloring; motor, movement; state, how awake they are; attention, are they attending to their environment; and then 5, self-regulation, can they do all the above by themselves without us? If at their core, at the autonomic level, they're not able to breathe on their own, keep their temperature on their own, how do I expect them then to do any of those harder things that I listed? So infants, fetuses aren't able to coordinate sucking, swallowing, and breathing until about 32 to 34 weeks. So if any fetus is born before 32 to 34 weeks, they're always going to have a feeding tube because they don't have the ability yet to suck, swallow, and breathe. So then when it comes to around 32 to 34 weeks, then the doctors might say, okay, they're around the age that now they have ability to do that. You can start working with them on feeding. But then we really don't expect them to get the hang of it until they're closer to full term. So until closer to the 37 to 38 weeks. Something else that's really interesting about this population is that premature infants, if they're aspirating when liquid's going down to the lungs, it's usually silent because they don't have the receptors yet developed in their larynx to produce a cough. So they might be feeding, drinking their bottles, something might be going down the wrong way, and they don't have any physical response to it. Instead, we're going to be going into what they might show instead to indicate that it's not going down the right way. So something that's hard for parents is that every time an infant takes a step forward in the NICU, something else might take a step back. So if, for example, they were on a lot of oxygen support and now they no longer need oxygen, that's great because that means that their lungs are now developing. But it might mean that their feeding is now not as great because now they're working on just breathing by themselves. And now I'm giving them something harder of, here, have a bottle in your mouth and stop breathing while you're sucking and swallowing. So every time there might be one step forward, there could be one step back. And that's just kind of how it is. Every single day in the NICU is something different. If we're going into states, we're talking about how awake is the infant. Ideally, we would like to be working with them when they're awake and they're quiet, that they're not fussy, they're not tired, that they're just in like a nice, quiet, alert state. That's the best time to be working with them on feeding and in terms of like learning something new. They're not going to learn well when they're drowsy, when they're in and out of sleep, when they're in a deep sleep, or if they're so fussy that they can't focus on what you're trying to teach them. So for example, here, one of this picture on the left was a patient that actually a parent brought into me and was like, oh, I can't wait till you see her eat baby food. I'm like, well, she's not awake. Like, why don't we wake her up first? Then at the bottom, we have a baby who's hysterically crying, looks like he can't even focus to the bottle going in on his mouth. And then the baby in the top right is what it would be a quiet, alert state, looking the most interested and engaged in the task that he's doing. So what can we do with these babies if they're not at the age where they can eat yet by mouth? In the NICU, like I said, we're on a schedule based on the nurses and the doctors. So how it works typically is every 3 hours, these infants have to get their temperature taken and their diaper changed. So for example, where I work, that happens at 8, 11 to 5, etc. So every 3 hours. So at that time is also when you do the feeding. So if they don't start eating by mouth until at 32 to 34 weeks, what we could start doing as speech language pathologist is when I'm doing their temperature and their diaper, I'm letting the nurse know, oh, look, he's starting to wake up. Oh, he's starting to take the pacifier. He's starting to show that he's interested. So I bet, in the next week or two, when he's at the age where he can start eating, he's showing already that he's having some cues or some interests. So besides the age, because age doesn't automatically qualify that they can start eating, we also want them to be stable. We want them to have little to no oxygen needs. We want them to root and suck, and then also be able to manage their own secretions. So this is the scale that we use at my hospital, and I've used at other hospitals. It's just an easy way to tell if you should be feeding a baby or not. Basically, the green signs are that if they are waking up prior to care, so prior to the temperature and diaper, if they're bringing their hands to their mouth, taking the pacifier, looking around, that shows green light, you should feed them. Compared to the yellow, maybe they're briefly awake, opening their eyes when they're touching them, but then they're asleep after you finish, not showing any interest at all in the pacifier. I wouldn't feed them. And then last, when you definitely should not feed them, is if they need increased oxygen when you're just touching them with temperature and diaper, or if they're breathing heavily just during those routines. We wouldn't give them anything harder to do. If we're looking at feeding, these are the skills that are I look at during a bottle feed. We're going to go into each of them, so I'm just going to pass by this slide. In general, we want all infants to feed at a maximum for 30 minutes because after that amount of time, they're actually expending more calories than they're getting in. So for them, this is an exercise. So if you're trying to feed a baby for an hour and they're not gaining weight, that could be why, because all of their energy is going to sucking and swallowing and breathing what you're giving them, and it's not being optimized in a good way. And ideally, as us adults, if you're just sitting down having a meal, and if you weren't out in a social setting or distracted or anything like that, you could finish your whole meal within 10 minutes. So thinking about someone continuously eating for a full 30 minutes is a very long time. So how do we determine if a baby's ready? So this baby is awake. Right when the nipple goes onto the lip, he's opening his mouth, and then he's accepting the nipple. In terms of a latch, so that means how the lips look around the nipple, we want it to be on the right, nice and wide. If you look at the upper lip and the lower lip, they're over 90 degrees. So that's considered a nice, deep, wide latch. Compared to the babies on the left side, one has his mouth open and isn't even closing his lip on the bottle. And then the baby on the bottom, she actually looks more distressed, like she's purposely pushing that bottle out of her mouth because it looks like it's coming down on her face and it might be too fast for the baby. So these are things that we look at when we give the baby the bottle. Then we're going to go into the first video here, which is looking at the actual sucking, swallowing, and breathing. So this is just going to be a quick one. So this baby, we see that has a nice wide latch, is awake, holding his bottle. He's continuously sucking and not needing to take any breathing breaks. He is able to lie down on the couch and drink his bottle. Like he's having no problems that we would think that we need to come in and intervene. Okay, let's compare that then to this one, this baby.
Like open wider. Let's get your little hands down here. We want to tickle baby's lips until they open, and we want to get that nipple all the way in. Come on. And if baby starts going, let's see here. If we get him to go, so see how he's gulping right there? Gulp, gulp, gulp. We don't want that. That is too fast. So if that happens, we slow that flow by either dropping. If we have to drop it so far that there's no milk in the nipple, that's fine. The air won't hurt him. But see how he paused? And then when he starts sucking again, we put that milk up into the nipple just so he can go suck, suck, swallow, pause. And when you have a baby who can pause with the bottle in their mouth, then they're getting that flow in such a manner that it's going to be more protective of breastfeeding than a fast flow would be.
So that baby, it seems like he was getting the milk too quickly from the bottle. So the person who was feeding him had to tip the bottle down in order to give him a breathing break. Something that's very common with premature babies, as they will do suck, swallow, suck, swallow. Oh no, I forgot. Breathe, 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 breathe. And a lot of the times that can get them into trouble in terms of their oxygen going down while they're feeding or the respiratory rate going too high. So that's where this comes in of we have a scaling that can tell us how coordinated they are. Can they just feed? I hold the bottle in their mouth and not do anything. Can I hold the bottle in their mouth and then they just get tired at the end? And then anything from 3 and 4 means that we really need to be pacing them to give them their breathing breaks because they can't do that on their own yet. And again, that's something that should just come with time as they get closer to their due date. So these are ways that we can help babies with feeding. We can feed them on their side, which is called side lying. That really helps slow down the milk going into the baby's mouth. It could also mimic the position that they're in for breastfeeding. And also having our hands on their back and their neck can help us feel when the infant is breathing. So again, we know right away to stop them if we feel that they're not breathing. Pacing them is what we just went over. Tipping down, sometimes it could be, you might have to count the number of sucks before tipping down, or other times you might just be tipping down as needed. We can also change how fast or slow the bottle is. And then worst case scenario is if all of that doesn't work, we could do a swallow study. And if we see that the baby needs a different thickness in breast milk or formula, we can change that. So earlier I was telling you, babies usually don't tell us by coughing if they're aspirating. So what are other signs that we might look for? This baby on the left has redness of the eyebrows and eyebrow furrowing. So again, showing that they might be stressed. This is a classic NICU symbol of premature babies. I tell parents they're literally telling you stop because something that's happening is overwhelming them, whether it be the bottle themselves or something else. If the baby was wide awake before you were feeding them, and now right when you put the bottle in, they just shut down and fall asleep, and then you take the bottle out and now they're wide awake again, that might be telling us that there's something stressful or not right about this bottle that they're shutting down right away as a way to get out of it. And they're so smart that they're able to do that. If we see any eye tearing during drinking the bottle, that again could be due to irritation from milk going down the wrong pipe. And then if we see any changes in their vitals, like their oxygen going down, their respiratory rate going up, those could all be indicative of stress or signs that the feeding isn't going the right way. So like I was saying, something that we can do is change the bottle or the nipple. So all bottles and nipples aren't made equally. There are some that are faster and some that are slower. So this chart is something for your reference if you're ever working in this area in the future, that this is slowest to fastest, how we can kind of change. Usually in the NICU, we have access to Dr. Brown bottles, which is on the right, and they have 8 different levels going from ultra preemie to a Y-cut. But most commonly too, we also have these disposable nipples, which are just used for a one-time use and then you throw them out. And that would be something like on the bottom, a Similac slow flow nipple. So it's hard because in the NICU, it's really convenient to just use a disposable nipple because, again, you don't have to wash anything. You don't have to get anything sterilized. You don't have to deal with different flow rates. But these nipples are really unpredictable, and not always a consistent flow rate. And then plus, parents aren't going to go home using these nipples. So instead, I'd rather get them on something that they will be using at home, even if it is a little bit more work in terms of teaching them about cleaning and sterilizing. Okay, now we're going to look at a few short videos for some case studies. So this one I'm just going to play, and I want you to let me know in the chat box what you see. I'm going to play it twice. It's about like a 15-second video. All right, now it's playing again for the second time. Okay. So yes, I saw in the comments, finger splay, so the hand stopping signs, the furrowed brow, refusal to latch. I never saw the baby latch once. He actually stuck his tongue out to prevent the nipple going in. Looked too agitated. Yeah, it didn't look to be in a calm, quiet state, stressed. At one point, he literally was like reaching his hand up, like, save me. So, these videos that I'm showing you are, parent videos that they're uploading to YouTube because they're look, first time feeding preemie with a bottle. But if I was there, I would want to help this parent by saying, first, let's like get the baby swaddled in a blanket. The baby's also being fed on his back. So let's move the baby to the side. Why don't we try swiping the bottle on the lower lip and wait for him to open his mouth instead of just, the kind of technique I saw was more like trying to shove it in there, which it didn't look like he really wanted to do. So again, this looks like a small young baby. This is an experience that's going to be laid down in his head like, oh, when this thing comes toward me, I don't really enjoy this. And now look, 3 hours later, it's happening again until it learns to be a repetitive pattern. And we don't want to do that. Now we'll go to the second video, same thing. It's about like 30 seconds long. Just let me know as it's playing in the comments what you see.
What?
Same thing I have for breakfast. I was like, what do you breakfast for lunch? And that's the same thing I have for breakfast. I was like, my something on cereal.
Okay. Hey, can't you see I'm turning white here?
Honey, why are you screaming that? He's not.
Sit down.
Okay.
Okay, so now they're going to be taking the bottle and giving it again.
Good boy.
So in that video, a lot of you guys got the overall gist of it. That baby also didn't look like he was specifically enjoying that experience. He was definitely drowsy, like you said, had the fingers splaying before the bottle even went in his mouth. Again, I didn't see him turn to the bottle at all. Only at the end I saw him sucking, but I think that more was like something's in my mouth and it's a reflex for me to suck, not I'm hungry and I want to do this. We saw milk coming out of his mouth. At one point he coughed, which means that probably a lot went down the wrong way. The baby wasn't swaddled. And again, it looks like he was more on his back than being held like either here or on his side. So now, once you start learning about these signs, they're kind of like things that you can't unsee. And then this is the last one. Okay, here we go. So this is now showing a video of a nurse feeding what it looks like a NICU baby, and she's actually providing really good techniques and information for, I'm guessing, the parents that are there of how to feed the baby.
Okay, here we go, here we go. And you touch the nipple to their cheek until they turn towards it. Thank you. And you notice how frantic his head was going back and forth, even though the nipple was in his mouth. When you have that scenario, you can always just tip the bottle down so the nipple touches the roof of his mouth, and that triggers the suck reflex. And that shows him where the bottle is, and he can start eating a little bit easier sometimes. Our substance exposed infants often have what we call this organized feeding. This little man does pause to self-pace himself, but sometimes they need help doing that. And see where he takes a break, and then he starts sucking again. It's okay to let him do that. We don't have to manipulate the bottle and spin it or tap on it or move it up and down. We can just let him do his own thing.
So that one, we see this baby is in a quiet alert state. He's on his side. He was actively rooting, like the nurse said, to the bottle, looking for it, latched right away, started sucking right away. And then she talked to the parents about pacing if needed, but it looked like he was taking his own breathing breaks. So just seeing the difference between this baby who's in the NICU, has a feeding tube, compared to the other ones from the other videos, it really gives you some of comparison and ways that, again, we're giving it a very positive experience talking to the parents, but ways that we can make this like a good experience for everyone. Because I think if you were seeing your baby being fed like the other two, you'd be like, why isn't this working well? Like, is it something I'm doing? Like, why is he, crying? So it's really to help everyone. Okay, so this is now we're getting to the last few slides here. So we're just talking about quality versus quantity. This is like the biggest debate in the NICU. That's a challenge that I literally talk about every single day. So these babies have to take their full bottles in order to go home. However, we also want them to do that in a safe and positive manner. So that's a really, really hard balance, because a lot of the times we could have very well-intentioned nurses or parents be like, look, I can just feed them like this, and they take the whole thing. And that means that my baby can get the feeding tube out and we can go home in 2 days. I'm like, right, but also, like, did we see that the oxygen was going down and the baby's hands were like this the whole time? And basically, in driving that home, I always tell parents that when you leave here, I want you to feel confident in feeding the baby. I want the baby to like eating. And I don't want to set you up for the baby needing to come back into the hospital because a few weeks or 1 month down the line, they no longer want to take the bottle. So right now, this might seem like a short solution in terms of twisting the bottle, tapping it, putting a nipple that's really fast on just to get more volume and quicker. But in the long run, it's not really a feasible solution that's going to be successful for the parent or the baby. So this comes up all the time. Someone who's a good feeder is someone who's doing what all of you guys were doing in terms of like identifying what we're seeing in the baby and following the baby's lead instead of just pushing for a number. Because I always say, like when I ask parents how a baby did with their feeding, I tell them to describe to me what happened and not just tell me, great, they took their full amount. Okay, but were they breathing okay? Were they awake? Like really driving home that that's what I care about. Because look at all these babies, if all of them were taking their full volume, we can see that they were showing us that they weren't comfortable doing that. Where does this idea come from? Basically, the doctors ask every day to the nurses, how much is the baby taking? The dietitians calculate a percentage every day, how much they were able to take by mouth and how much had to go through the feeding tube. The parents want to know because it's a step closer to discharge. And then sometimes the nurses might see, oh, at nighttime, it looked like the baby was taking their full amount. So now that I'm working during the daytime, they probably also should be taking their full amount if they were taking their full amount overnight. So there's like a lot of factors in play here, a lot of different roles in terms of staff. So it's constantly something as like a feeding specialist and a neonatal therapist of what we're constantly educating about and why I care more about quality than the quantity. So what does that mean for us? I'm doing education, this kind of education every single day, every interaction I have with nursing, every interaction with a parent, in services, monthly educations, training new nurses. It's the only way really to help get that point across. And because we can't lose focus of this, that every time we're touching them, feeding them, doing something, we're forming their brain. All right, and this is the last topic here, briefly talking about swallow studies. So we can do swallow studies in the NICU. We could either do MBS or FEES. In MBS, we could actually put them on the table here to mimic how they would be fed in side lying. Or if they're big enough, we can put them in a little chair that's on the right and then take a video picture of their swallowing that way. So this is an image of a baby who's getting a barium swallow study. This is the nipple in their mouth. The black is the barium. And we see where the majority of the black is in the back of the throat. That's to the esophagus. And then where that's that little curl, that's entering now into the airway as aspiration. When I'm setting up for swallow studies, I have all different kinds of nipples and bottles if I have to go faster or slower. And then we also have availability for FEES, which is where a small camera goes into the baby's nose. And that way I'm looking directly at their larynx. And then we feed the babies with their bottle. We dye it green. That way we can see clearly if it's going down the right way or if it's going into the trachea. And this is what I just told you in terms of long-term impacts. Why do we care about this? 20% of NICU grads will experience continued feeding difficulties at the age of 1 to 2 years old, and 50% of premature infants will present with some kind of feeding disorder, regardless of how early they were born. So that could look like later picky eating, refusal to take the bottle, things like that. And then they only have their sucking reflex until 3 to 4 months of age. Anytime after that, they then are choosing if they want to participate in drinking or not. So they might be like, oh, they fed great in the NICU. Well, they also didn't have a choice. Anytime you would put something in their mouth, they would suck. Now they're like, oh, all those 3 months of horrible experiences, I actually don't want to do this anymore. And that's when I might see them readmitted into the hospital. If you guys want to learn more about this, found this really interesting, this book on the left is one I still refer to all the time, and it was really helpful when I was doing early intervention. It's called Pre-Feeding Skills by Morris and Klein. It's a very large book, but it's really helpful. Then I have websites here up top, some known feeding specialists in case any of you want to look them up, their websites or continuing ed, and then some courses on the right that I found to be really, really helpful for this topic. So in general, it's our responsibility to protect our most vulnerable patients who are our pediatrics and neonates. Feeding disorders are not only seen in the hospital. Again, these babies grow up to be toddlers, school age, to be older adults. So that's why we need to be knowledgeable about from the beginning how this starts. And I think that this should be talked about at least in all graduate programs. And this is my personal email. So if you have any questions or anything like that, you can contact me there. And then I also have my LinkedIn attached as well. Thank you.
Thank you so much. I learned so much from this. Thank you. Anyone have any questions? I think there's one in the chat by
Oh,
Kenny.
okay.
He says, do SLPs have to sign off on a discharge, or can nurses override the decision?
Yeah, so yeah, that can be overrided. They could say like the hard thing is as a therapist, like right now I have 30 babies on my list. So I'm obviously not able to get to them every day, or I might see them once a week. So it's very easy for nurses or anyone who's feeding the baby to say like, well, you only saw them once and it was when they were tired. So that's why they didn't drink well for you, but they're drinking great for me. So that's like a really hard balance. I do see like if it looks like they're leaving within the next day or two, I will try harder to get to them to make sure that they look like they're good to go in terms of feeding. And if it's something that I do have a lot of concerns about, then I will tell the doctors, hey, I know the baby no longer has a feeding tube and they're planned to go home tomorrow, but I got to tell you, like, they really did not look good with me and I'm pretty concerned. And then they can take that into consideration and either choose to keep them or to let them go home. But it's really, I guess, still the doctor's choice.
Yeah.
I'm looking to see if there's.
Alexandria, I'm sorry.
Uh-huh.
Alexandria, she says, I'm in my last semester of grad school and currently taking a peds feeding class, and
Mm.
I love it. Do you have any advice for someone who wants to get into the NICU? And do you think EI is a good place to start?
I think it's a good place to start because before getting into the NICU, you have to have a foundation of birth to 3 and knowing what's typical or normal before comparing it to what's not. I didn't know originally that I was going to go in the NICU. I just kind of started in early intervention and then my journey went from there. But it was really beneficial to have. I will say it is really hard to get into the NICU just because of how specialized it is and how complex it is. But either finding a hospital job right after graduation, or if that's not possible, going into early intervention and then making your way, I think is completely fine to do.
And there's another question. I'm currently a recent graduate of obtaining my master's degree. What is your suggestion on what way to go when you are trying to eventually be in the NICU?
Yeah, so I only have one friend who got in the NICU directly out of graduate school, and it's because she had one of her placements in the NICU where she ended up doing her fellowship. Aside from that, everyone else I know who is now in the NICU got there because of getting experience with infants first and with hospitals and acute care, and then years into it, then would end up getting into the NICU. It is something that is considered more of like a long journey than something right after graduate school, just because it is such a small population.
Another question. What's your first year like in the NICU?
Mm-hmm.
And what's the
It was a large learning curve. So I did come from a children's hospital. So I was working with infants and toddlers and teenagers, but it is a different ballgame in terms of working with babies who were premature. That everything basically I provided in this presentation was all new information to me. I didn't know any of that. So I did have someone who was specifically assigned to me in terms of mentoring. And basically, unless she was worked part-time, so that was a little complicated because she was 3 days a week. So basically, when she was there, I was with her hip to hip, shadowing her, and then eventually like doing hands-on experience. But if she was not there, I was not allowed to go to the unit. And instead, I was taking continuing education courses to get more foundational knowledge. But my whole process, even having 5 years of pediatrics and hospital experience under my belt, I still had to be with my mentor for 6 months, like one-to-one, before I was allowed to see these babies by myself. So overall, it was a really supportive experience. I did get a lot of help. I'm not really sure how people can do it without mentorship because it's a lot to navigate.
we have some great comments.